Hi, my name is Francisco Villa, and today I will be talking about digital phenotyping in bipolar disorder and schizophrenic disorder and depressive disorder as well. And all this digital phenotyping is to basically allow us to have data that we can prevent relapses before a patient can go to a hospital or urgent care or any full-blown manic or depressive episode as well. Why relapse is so important in managing this patients? Uh, be, be, because relapse it's so critical in these conditions like bipolar, schizophrenic, and depressive disorder, because given the increased suicide risk, increased risk of psychosis or manic episodes. And unfortunately, relapse is very common in these disorders. There are studies that have shown that around 50 to 60% of patients, despite on treatment, they've shown to have relapse within a period of 2 years, maximally 2 years. And the concerning is that, you know, despite being on treatment for either bipolar or schizophrenic disorder, there is a relapse. And how do we monitor this? This is where, sometimes when patients have an episode, it's hard for patients to communicate. It's hard for patients to come into clinic. It's hard for patients to call the clinic and ask for an advice. Majority of the time or cases, patients don't know what to do next, or even family members don't know what to do next, whether to take the patient to the hospital, whether to wait and take the medicine or double up on the medicine, which is majority of times can be crucial for the patient. Um, so relapse periods are also associated with, as I mentioned, higher risk of suicide, probably patient not taking medications, and probably patients just not wanting to accept a condition. The challenges in this, occurs suddenly. In many cases, there are early warning signs that are given daily or even weeks before a patient can have a full-blown episode. If we are able to detect those early signs sooner, we have an opportunity as clinicians and staff to intervene early and potentially prevent some sort of hospitalization, emergency setting, and basically prevent a severe symptom escalation for these patients. What is digital phenotyping? Digital phenotyping basically is using artificial intelligence in these new AI models, for example, smartphones, iWatch, Androids, Aura rings, those new rings. We have all this data in our hands as patients and family members that we can use to track a patient with bipolar and schizophrenic disorder. And basically what this AI data does is that it collects data from the patient, such as sleep pattern, activity levels, heart rate variability, mobility, and with all these patterns, it will give us continuous behavioral patterns and see if there's no any changes with all this. So the idea of this digital phenotyping is that it will provide us with behavioral and physiological signals that can serve as early indicators of mental health changes, specifically for this type of patients. For example, if we see a change in sleep, activity, or daily routine that may occur days or weeks before a relapse becomes clinically obvious, then with this, we can intervene sooner and prevent that relapse. So by analyzing these patterns, we are able to identify early warning signs. And as mentioned, intervene sooner. In this schizophrenic research that they did back in 2018, they used smartphone basically in this data. And what it showed in this graph is that patients using this digital phenotyping and clinicians were able to detect they had a window between 10 to 14 days to intervene before a patient had a full-blown episode of psychosis or manic episode or depressive state. Um, so, in other words, this measurable behavioral was to prevent a full episode, and before it become clinical relapse, you can see it more obviously by measuring these biomarkers. So it suggested that in a period of 10 to 14-day window, we can intervene and potentially prevent a full-blown symptom or also prevent a hospitalization for this type of patients. So these findings support that the idea that behavioral data from everyday devices such as smartphones and all that artificial intelligence that we have in our hands, smartphones, watches, Oura rings, it can help identify early warning signs of relapse. In this other study that was done back in 2020, it showed different activities with sleeping pattern with schizophrenic and bipolar disorder. As you can see, there was basically it was a control data versus bipolar and schizophrenic disorder. As you can see in comparison, the larger blue box show that schizophrenic show a higher incidence with less sleeping pattern. And in bipolar disorder, it show a high risk, but not as high as schizophrenic when having someone low sleeping pattern. So basically, uh, to say or clinically is that sleeping pattern or sleeping instability are the central features of schizophrenic and bipolar disorders that we need to monitor continuously using these biomarkers that are not available to us. And this other bipolar research that was done also the same year in 2020, it showed how bipolar disorder intervenes with daily life and also how sleep duration can alter bipolar disorder as well. So it showed that manic episodes or disturbances are linked to shorter sleep duration. So as we sleep 3 or 4 hours and we have a diagnosis of bipolar disorder, we can have a manic episode the following day or that following morning. So overall, this AI or digital phenotyping can give us that early biomarker of pattern of sleeping. And then as a clinician or staff, we can intervene and assess the sleep hygiene or see what's happening, adjust any medication that we have to adjust. And also we can contact the patient and say, you need a sooner follow. So, clinically, it's important because reduces sleep. It's often one of the earliest warning signs of manic episodes or psychosis or depressive episodes in these patients. What data or what devices can we use for this data to be analyzed? Basically, as I mentioned on the previously, is that we can use iPhone androids, because with that we can use those devices to assess the biomarker of how much a patient is being on their phone, typing, probably texting frequency, if their text is more slower, faster, if they're about GPS mobility, if the patient is walking too much or too slow, or basically there is no mobility at all. With Apple Watches and smartwatches, we can also assess the sleep duration, whether the patient is sleeping 7 hours to 9 hours, which is a baseline, and then compare that if there is some sort of abnormality. Patient is sleeping 15 hours, patient is sleeping 3 hours. And also with this watches, we can assess the activity, the resting heart rate, um, how many steps in a day. It would have a baseline. With the Aura rings, it also monitors sleep pattern, staging. It gives us phases of where we at. It gives us heart rate as well. It can potentially also give a temperature. Um, so, this data, or digital phenotyping, by using this new devices, which majority of patients already own, can give us all these biomarkers to assess the patient sooner than later. And basically, this every devices will allow to collect objective behavioral data, and with that can provide early warning signals, and it will also show signals of a clinical instability. So with this, we can, as our office, we can intervene and talk to the patient or family members at that point. How this AI works on these devices? Basically, it works in three layers. Basically, we have the inner layer, which is the input layer. We have the middle layer, which is the hidden layer, which is where interactions occur. And then we have the external or output layer, which is the relapse probability. In this neural network, it's where all mathematical algorithm occurs. That's where all your biomarkers, heart rate, sleeping pattern, breathing pattern is going to be analyzed by setting a baseline of, for example, 8 hours of sleep. If we all of a sudden we see some sort of change, then this neural network that it's provided by this artificial intelligence will give us a relapse probability. It will give us a relapse probability that, okay, sleeping pattern has changed 20, 40, 60%. Um, And then with that, we can, see we're going to receive an alert, and then we can assess the patterns of every day to see if the patient is taking the medication, to see if there's any changes in basically their social life. And the goal of this digital phenotyping and AI is to basically not replace the clinical judgment of a physician or staff member or any provider, but basically is to provide biomarkers and provide early warning signals to support and to support care and be able to intervene sooner. How this AI and digital phenotyping and changes in biomarkers can we see that? It's by clinical workflow. Basically, with this AIs, once we set up an application, it will send us alerts directly to the office, which will be reviewed by staff members, physicians, MPs, and PAs within a 24, 48-hour range. So that's pretty quick. Once we receive the alert, we can review what type of alert it is. If the patient has had some sort of decline in sleeping pattern, or the patient has had decreased mobility, 40, 50% decrease. This is just a probability. It's not, like I said, it's not a diagnostic tool, but rather than just to provide us with biomarkers information by using artificial intelligence, that it's going to turn that into a probability. And basically with this, once we receive the alert, we can do the triage portion where, hey, how's the sleeping pattern? How you're taking your medications? Any substance use? Have anything has changed? Have any stressors? What are the safety patterns? And once we review that with the patient, then we can intervene. Okay, let's come up, for example, in this situation, let's come up with a sleep plan. Do you need any help or assist to sleep? It's going to be a more rapid follow-up. We can do adjustments to medications if we have to, and we can literally also engage with family and add any sort of support for the patient and family members um, to better assist the patient. And the goal of all this is basically to prevent a patient from having a manic, a psychosis, or a depressive episode that can lead to hospital or any suicidal thoughts or any suicidal risk. And the goal of all this as well is to intervene early warning phases before symptoms escalate into a full relapse that may require hospitalization. So, this entire approach shifts psychiatry from reactive care to more proactive and preventative care. And to conclude, there is a few key takeaways or a little summary that bipolar and schizophrenic disorders, despite taking treatments, you can have a relapse. With this artificial intelligence, it's to collect data or biomarkers, sleeping pattern, heart rate variability, any daily social activities that you do. Also, all this data, it's in our hands. Now we have Androids, we have smartwatches, and basically AI. As a patient, you don't have to do anything other than just wear these devices as instructed by providers, staff members, for us to receive those biomarkers, that probability percentage. And AI will provide all that to our office. We'll get an alert, and that's how we were going to intervene. And basically, with this, we can intervene as soon as possible within 24 to 48 hours. AI, it's future, and it's in our hands. So we should take advantage of that artificial intelligence in a way that it can help us help the patient with bipolar, schizophrenic, or any depressive episodes that can lead to higher incidence. Thank you very much.